Epinephrine, so with or without epi for your lidocaine. So actually there is some evidence about it. The pros are that it's gonna give you some local vasoconstriction, so it's gonna decrease the rate of systemic absorption, which is definitely something that you will like, to decrease the systemic toxicity. It could increase the rate of local anesthetic as well, just because it's not reabsorbed, so it stays more in the area of interest. So because of that, it's going to increase the direction of action. And then if you use Lido, how much can you use? So it depends on if you're using epi or not. If you are using epi, then you can use more, because not as much goes into the systemic system. So you can use up to 7 milligrams per kilo of lidocaine if it's with epi. Otherwise, it's going to be 5. And just I did a little math for you. So per 10 kilograms, if you use Lido 1%, you can use max 5 milliliters of Lido without epi, or 7 milliliters of Lido with epi. It usually lasts for 3 hours, 3 to 5 hours. Sometimes if you use something else, like Pivacaine, it's going to last longer. And here's a chart just pointing, depending on where you want to do your block, how much you're going to need. It's the one that you usually use the main quantity of lidocaine. Otherwise, it's more up to 5, 10 milliliters. But femoral block can go up to 20 milliliters. So definitely keep that in mind if you are doing a block on a little child. But if you are doing your block with ultrasound, you also know that you're going to need not as much. So use your ultrasound. Is mainly for you to keep, and depending on where you work, if you don't use Lido, so Lido is here, but you also have all the others anesthetic that you can use, and how long it takes for them to kick in, how long they are going to last, what is the can give, and some notes about it. So it's definitely something that can be very useful depending on where you work. The technique now is really as when you do a kind of soft tissue scan. So you have your linear probe, you want to scan the area of interest. And usually what I would advise is to look first to make sure that you know where the nerve is, where the vessels are, where you're going to be willing to do your local anesthesia then, because then you know where you're going to be poking. So I would definitely recommend to just have a quick look first. The patient, put the local anesthetic on, and you get your everything that you need. How to recognize the anatomy. So here, it comes from a very, very good website, Sonoguide, that I advise all of you guys to use. Right now, they are a bit in work. They're doing some work on the website, but still there is a couple of things that you can still access. So here is how it would look like with your ultrasound. So you have some muscles here, you have the vessels here, and here is your nerve. So if we put the anatomy on, that's how it would look like. So here you have your muscles, your vessels, and here your nerve bundle. And if you have only the anatomy, that's how it is. Nerve is something that can look very hyperechoic, as here. So here you can see the nerve in the middle of the screen. So it's usually the sheath around is very hyperechoic, and then the center, so where all the fascicles are, can be either very hyperechoic as here, or not hyperechoic at all, meaning completely hypoechoic here, which is because nerves have that propensity so they have that isotropy thing, which is as diamonds actually, meaning that depending on how you look at the nerve, it's going to look different. So use that when you use your ultrasound probe to make sure that you see the nerve or not. And how? Actually, it's just by fanning your probe. So if you look at the area of interest, you know that there is a nerve there, but you're not able to see it, just fan through. And then by doing it, you're going to see that it lights up, it lights down. And so then you know where the nerve is. That's pretty useful. How are you going to approach with your needle? That is also something that is very important, just to make sure that you know where your needle is and where to go with your needle compared to your probe. There is 2 ways of doing it. Either out of plane, meaning that you come perpendicular to your probe, or in plane, meaning that you come parallel to your probe. In plane is the way that we usually do it because it's the safest way. Why is it? It's because actually coming that way, you do fold the tip of your needle all the way through up to the nerve. And that's what you want to do because you don't want to miss the tip when it's touching the nerve. So that's how it would look like. So here you can see the tip of your needle that is close to the nerve here, and then you're injecting some fluid, and it's just so you can see the hypoechoic fluid around the nerve that is really kind of dissecting the tissue, and that's definitely what you want to see. The needle tip is here. Oh, it doesn't show. Okay, anyway, it's at the right, top corner. So you see the needle tip here, and then you see the fluid coming around. The patient usually would first feel some kind of warm feeling, and then some tingling, and then some numbness. So you can always ask them if they're old enough about what they feel. Here, so depending on the needle and how you catch the needle, that is something else that you can see, which is the reverberation artifact of the needle. So that on the left side of the screen, you can see the reverberation artifact of the needle. So if we go back to our case, now that we know that we can do a nerve block, it's safe, and it's the literature is supporting us. We know that the femoral nerve can be a good block here for that patient, and we know how to do it. Let's do it. So femoral block, for that, you need to know your anatomy for sure. So where are you going to access your nerve? It's in the inguinal area, where the nerve is close to the artery. So the mnemonic that we use in Switzerland, at least, is even, meaning I for interior, and then vein, artery, and nerve. So your nerve.
Just remind you that we're recording that, so you don't put your mind.
The person I will give a shout out to is named Sheeta Shafi. She was an O fellow. Introduced me in a New York accent to Venus towards Venus.
That is another way of remembering it, for sure. So the nerve is the most lateral structure. And what is important to know is that if you look at the anatomy here, you can see that the nerve is a round structure, kind of in cephalic way, but then it becomes a lot of different bundles. And the artery does exactly the same thing, not as much bundles, just two, but still. So keep that in mind. If you see only one artery, great, you're at a great location. If you see two artery, just move cephalic a little bit so that you can catch just one femoral artery and not the two. And that's where you should be injecting. Give you a good sensation block of your thigh and the inner part of your lower leg as well. It's also going to give you some motor anesthesia of the quadriceps, which is actually very useful because usually when you have a femur fracture, your quadriceps is completely contracted and very painful. So doing that block is going to work that pain as well. Puts everything together around the patient. So you want the patient to be comfortable and you want the machine to be comfortable. Meaning that with your eyes, you want to make sure that you can see the patient, what you're doing with your needle, you can see your probe, and you can see your screen. So either you do that way, meaning that the machine is on the other side of the patient. Some people would still keep the machine on the same side of the patient and then inject with their right hand. And that will work for the right femur, for example. But it's really up to you, like find out which way you prefer. For sure, you want to use your dominant hand to move the needle in. And your other hand should actually be holding the probe. Some people have tried to have the probe held by someone else. That doesn't really work very well. I feel like if you have someone else available, use that person more to either record what you're doing or inject the medication. But the person doing the procedure should at least have the probe and the needle in their hands.